Assalamu alaikum. Now the clinical station approach to a child with tall stature. So entering the room, wash my hand, hand over the mark sheet, and then greeting, hello, me Dr. Rokshana, one of adolescent doctor. Usually, if the child is adolescent, and then are you confirm the child and parents name, are you Fatima, and mom, how are you, and explain the role. Today I would like to examine your child. This examination involve the different parts of your body. In addition, I will see her gait, is it okay, and then I will look in this stage. She is communicating well or not? Is there any dysmorphic face present or not? Is the child in distress? Any hearing aid? Any visual aid? Any walking aid present or not? And what about the dimension? I want to ask the examination to know about it. Then he may show any growth chart which may show that there is the height is above the 95th centile. Okay. So from this we can get the it's a case of tall stature. And now the maneuver is just like we will start from this. I will do the inspection, and after inspection we will inspect from the front, side and back. And then in the front we are looking that is there any obvious deformity present or not? On the side and on the back, is scoliosis present or not? And then after eye we will do uh, after eye we will start with the J, and G is for the general inspection. I After I, then we will do the M. I M, and after eye inspection we will do the maneuver, and this maneuver includes the upper limb, neck and the lower limb. For the tall stature, the maneuver will that can you put your two palms together, and here I will see that is there any asymmetry present or not, and then which is commonly present in back with white man syndrome, neurofibromatosis. And then can you make a fist for me, and then can you make a star after feasting for short fourth metacarpal, and can you make a star for is there any arachnodactyly present or not? And then as we are suspecting that is a case of tall stature, so we will do test for arachnodactyly and also for hypermobility. So for test for this arachnodactyly we can do that thumb sign and the wrist sign. And for hypermobility, hyper expansion um, of the wrist joint, and hyperextension of the finger more than 90 degrees. And then the second maneuver is can you put your feet together, and here we will looking for any hypermobility sign of hypermobility sign of the knee joint, and also is there any pis planus present or not, and also any genu valgum or genu recurvatum deformity present or not. This is from the uh, inspection. We do the inspection and the maneuver IM. And then we can do the, you can see at the side is his or her resting behind below the mid thigh or not. And after that at the back, is there any scoliosis present or not? And then we will tell the child, if we suspect there is scoliosis, to confirm it we can say the child to touch the toes And then for hypermobility, can you put your palm on the floor without bending the knee joint? For hypermobility. And after this, I am then maneuver is finished, then we will do the general examination. In the general examination, in the hand, for any sweating present or not, any tremor present or not, pulse, and what is the rate, is it regular or not, and then we will ask for measurement of the blood pressure, and then to measurement of blood pressure, or at the face, is the highest palate or pleasant or not, and then on the chest, is there any chest deformity and scar mark present or not, and then if we are suspecting this Marfan, with permission we can see the aortic regurgitation, dissection, or which we can find by asking leaning forward and breath hold in expiration, and then we can see the hernial orifice with permission, and then I want to see the IMG for the general examination, and another G for the gait. I want to see the gait of this patient, and then after finishing, in order to complete my examination, I want to do I want to measure height, when height, circumference, upper segment, lower segment ratio, check the growth velocity, check the growth chart, ask for mid-parietal height, fundoscopy, arm span, tenor staging, and Byton scoring. This is the approach to tall stature. And causes of tall stature, first the is familial, second is obesity, and third is endocrine cause, and fourth is syndrome. So in the endocrine cause, there may be the causes of tall stature, which we can consider that uh, precocious puberty, hyperthyroidism, and the syndrome, Marfan syndrome, homocystinuria, um, and other syndrome that and there are two other syndrome that we can include in tall stature is Sotos syndrome, Klinefelter syndrome, and Beckwith-Whitman syndrome. And if asked about the investigation according to the clinical presentation and history and the clinical presentation, it may include the bone age, thyroid function test, karyotyping, insulin-like growth hormone 1, and sex steroid. And this is all about the approach to a clinical approach to a tall stature. Thank you.